Welcome to Afternoon Tea. I'm Dr. Linda. I'm an emergency physician, and I'm here with my lovely co-host, Dr. Erica, who is a GP, and we are both lifestyle medicine physicians. I'm tuning in from Sheffield, and I'm having a lovely cup of decaf Earl Grey. And what are you having, Erica?
I'm also having a cup of Earl Grey tea from the West Midlands. So every Sunday at Afternoon Tea with Docs, we bring experts to the table to inspire and empower you to enjoy good health by sharing fad-free information. We believe in changing our health one conversation, one habit at a time. In the audience, we have people from all walks of life, and we encourage you all to ask questions in the chat or later face-to-face with us so that we can all learn from each other. And we particularly love to hear from non-medics and the sort of questions that you may have for a healthcare professional.
Today, we have two very experienced clinicians joining us to talk about the art of communication with the patient-doctor relationship and the power of narrative medicine and how this affects the outcome and the quality of care we provide.
We're delighted to have Graham Stevens join us today. He is an internationally qualified lifestyle medicine practitioner with 35 years of experience, knowledge, and research. He has a special interest in providing evidence-based alternatives as a way of treating many modern-day chronic health conditions. He is the North Wales, Cheshire West, and Chester Director of British Society of Lifestyle Medicine.
We have Mehl-Madrona, MD, graduated from Stanford University School of Medicine and trained in family medicine, psychiatry, and clinical psychology. He has been on the faculties of several medical schools, most recently as Associated Professor of Family Medicine at the University of New England. He is interested in how we can train new doctors to be simultaneously humanistic, narrative, and evidence-based. He has also authored many books and serves on the board of directors of the Coyote Institute for Studies of Change and Transformation. Welcome to you both. Thank you for coming.
Thank you for having us.
Yeah.
We would love to ask you about what does it mean to be a doctor? And what is the definition of a doctor? If you can start there, Luis.
Well, shall I begin? So maybe a story. When I was in college, I was trying to figure out what I wanted to be when I grew up, and I was debating between going to medical school, divinity school, or becoming an astrophysicist. I thought those were the three things that interest me, and I thought, well, I like science, but I like spirituality and religion, and I like people. So medical school seemed like the best choice. And I was, when I got there, I was a little shocked because they didn't have a course on healing and they didn't have a course on spirituality either. And, before we went live, we were talking about my my experience of cognitive dissonance, and I was sitting in a lecture, and a famous person was talking to us because I went to Stanford University where only famous people were allowed to teach, and everyone had a prize in something. And this was the guy that discovered the metabolic syndrome. And so he looked at us and he said, "Boys," which was because he couldn't admit that there were girls in the class. He said, "Boys, life is a relentless progression toward death, disease, and decay. The physician's job is to slow the rate of decline." And my, my great grandmother, who was a Cherokee, indigenous Cherokee healer, always said you should die healthy so you can party on the other side. And so she didn't believe that you had to be sick to die, or that if you were sick, it meant you were going to die. She hadn't, in her worldview, sickness and death were not connected. They were entirely separate phenomena. And so I was quite shocked by this way of thinking. Though, I can understand the perspective to some degree, you know, but at the time it was very upsetting to me. And so I ran across campus to the Stanford Indian Center, and I burst through the door, and there was Henrietta Blue Eyes at the desk. And I said, Henrietta, I need an elder. I need to talk to an elder. And she said, what tribe? And I said, Cherokee. And so she got out that archaic artifact known as the Rolodex and rolled through it and gave me two names. And so by the next weekend, I was in Ukiah, California, talking to an elder named Gila. And, and that connection with elders kept me going through medical school in the sense of it fed my soul in a way that Stanford medicine didn't entirely. Though I will say, and you can please stop me if I'm talking too long, because I tend to talk too much. Um, I will say that Stanford psychiatry in those days was so much more narrative and humanistic than what we find now. We had one of my supervisors as a medical student was Roger Walsh, who's become well known for his work in spirituality and psychiatry. He now teaches at UC Irvine. And my group therapy supervisor was Irving Yalom, whom everyone's heard of. Um, and and he was quite existential and humanistic, um, and we were really quite interested in people's life stories and finding out, um, you know, the plots that they were living. So much more so than what I find today in psychiatric training.
And that brings us on narrative medicine. Graham, what is narrative medicine? And how do you use it in your daily practice?
I think the first thing for people to understand on both sides, the sort of doctor side, and I'm not a doctor, but is the fact that narrative medicine is a medical approach. It's recognized in that way, and it's where it uses people's narrative in a clinical way. And in some of my work, in on I use the term on the ground. So I've sort of worked at every single level possible, from Manchester's youth gang scene, in terms of change, and in all of these, including up to and including people who have had amazingly successful businesses but have lost who they are, perhaps certainly lost who their pet is or who their children's names are, because they're wrapped up in this ultra fast world or modern world. And so narrative is in all of us, either because we're chatting internally about something, whether that's in a fun way, happy way, or grumpy. And it has to go somewhere, it has to vent. And obviously that's can affect us in many different ways. So that narrative that we're using internally might not be what's expressed externally. And so we then have a conflict going on in that direction. And I'm sure in the doctor's world, from doctors that I've worked with, that's quite dramatic. And sometimes it's difficult for them to sort of get their head around how they're going to deal with that, because of the conflicting narratives. And I think as they begin to understand that in themselves and in a relationship with the patients that they've got, it really does encourage the creativity within themselves, certainly in terms of self-reflection as a physician, and therefore find it therapeutic.
Mhm.
So yeah, it's narrative is in all things from any age, and it's how it's internalized and how then they externalize it. And we may touch on that a bit deeper later, if it is that's what people want to do or want to ask about.
I mean, both of you have had a lot of clinical experience in your years of working. And I'm just wondering, in your experience, what has worked in a patient-clinician relationship, and what doesn't work so well? And we'd love to hear from you in the chat as well, whether you're a clinician or a patient. In your experience, what's worked in your relationship with your doctor or your patients or other healthcare professionals?
I could start. I've got a story about that too. So, once upon a time, a woman walked into my office and announced that she'd been hospitalized 375 times and had attempted suicide 80 times. And how was I going to fix her? And so I looked at her and I said, it's a good thing that you're not very good at committing suicide. And so she proceeded to tell me for the next 6, 7, 8 hours of hourly visits, all kinds of stories about her satanic abuse growing up and just incredible stuff. And on the ninth visit, she sat down and I said, "Well, what will you tell me today?" And she said, "I don't know. I've never got to tell the whole story. I don't know. I've never been here before. I've never gotten to this point where I've told the whole story and someone's actually listened." And I said, "Oh, well, if you don't know what to do, why don't I tell you some stories?" And so I started telling her stories. And occasionally she would ask me, you know, to change her medication. And I would tell her, I would say, "Well, you tell me what you want to change it to, because you know more about psychiatric drugs than I do, because you've taken all of them, and I've only prescribed them. So, you know, whatever you want to take is fine with me." And so, she would mess around a little bit with her medications. It never made any difference. Um, and so for a year, I kept meeting with her 1 or 2 hours per week. And it didn't seem like anything was happening, but as one of my colleagues pointed out, she didn't attempt suicide or go to the hospital for that whole year, which was a radical change in her story. And but she complained miserably every week, and I just kept telling her stories. And at some point, um, we decided that we would add acupuncture to the storytelling. And so I started putting in needles and telling her stories. And I think it was about, I think a year went by of doing this. And one day she came in and said, "I'm bored with being mentally ill. I'm ready to stop." And I said, "Oh, really?" I said, "How will you do that?" And she said, "Well, I've already started. I've begun to eat well, and I've started exercising, and um, I'm gonna wean myself off all my medications because they don't do anything anyway," she said. And I said, "Well, it's good that you finally came to that awareness." And she said, "I'm gonna start going to all the groups that you offer." So in those days, we had 3 groups. We had chronic pain group. Many of the patients had to come in order to get their pain prescriptions. So some of them were grumpy bears. And we had a group called Complicated Minds. We tried to call it anxiety group and no one would come. And then we tried to call it Hearing Voices Group and no one would come. But when we called it Complicated Minds, everyone wanted to come because everyone has one, don't you know? And and then we had a group that we called Fragile Minds, which were the people that couldn't tolerate complicated minds. And so she went to all three groups, and and slowly but surely she got off all her medications, and she got off disability, and she began making a living and working. And it's been 8 years since we stopped formal treatment. And she sends us Christmas cards and, checks in from time to time and is doing fabulous. And so I think um, there's something to say for just sitting with people, even if you don't know what you're doing or, or what or what's happening.
That's an incredible story. Thank you, Louise. There's a lot to learn from that story. With gosh, um, with that in mind, Graham, I know you are have started an organization, a charity, where you use narrative medicine and storytelling. From something as simple as working with woodworks to wellness. Could you tell us how did that come about, and how are the community is benefiting from it?
Um, the the origins of it was quite sad, really, because I'd spent 3 years with a very substantial men's shed in the UK and around the world now. Even America, they're growing quite quickly. Canada's also growing. Australia is pretty much where it all started, and it's essentially where the older men come together, because we know that they're a difficult group quite often, in terms of saying perhaps as it is, or communicating with other people and things. So it was very clear right from the very beginning that these sheds where the men met and were more over the shoulder type of learning and conversations just seem to have, it's often termed as magic dust, where they start to talk to one another on every level. Initially, it's very low key, perhaps more around how to make something or how to overcome a problem in trying to make something or whatever. So what we have there is problem solving, and the sharing of stories with each other. It comes into this kind of soup, this sort of broth thing of all kinds of ingredients going in. But every single one of them ingredients has a positive to it, because they open up like I've never seen, really, even in my earlier years. So it just has something about it. And I think the thing that it has is, Lewis has just touched on, is where you just speak openly, where you're actually able to say as it is, and be really genuine. Maybe in the sheds, that's because, they're with other men primarily, although our shed is very different. I'm just outlining here that process where men, older men in particular, the original type men's sheds projects were, um, are able to diffuse everything else and be present in that particular moment to start to grow something different to what they were growing before. Lewis commented, with the lady there, she eventually realized that maybe I need to change my story, and of course then directed Lewis. so and it does happen that remarkably often, given the chance. Is really about what process are we giving them, where they do have a chance. And I think that's where, like Linda, you've touched on earlier, losing that connectivity with patients, and that that that's happened, and you're and other people like you are pulling that back so that you can get between the two extremes. And of course, projects like ours are very able to do that. However, we have Ladies' Day, we have Ex-Forces Day, we've got the Young People's Day, and we have days where all of them come together in the same day. So all the different groups that we have can come together and fuse. So you have all this kind of magic going on, of which for me, it's a real privilege to be a part of, because you just see it all happening and I do nothing. I just watch it all. Occasionally, I will start a story off, but it's very quickly that they shut me up and then they carry it on. And that's fantastic.
So this is about the storytelling, right? So in today's practice, where so many physicians are burning out, we talked about burnout related to lack of connectivity with our patients. Louis, I know you lecture on this. Would you have any suggestions to our clinicians on the ground? What can they do on a daily practice to improve their own mental health? How can they turn the story so that they can connect with their patients again?
Well, I think as physicians, we have to take some control over our schedules. And I know many of us work for organizations that tell us how many patients we have to see per hour, and we have quotas, and we're in. I remember in one hospital where I interviewed, they called the physicians um, service provider units. And so I didn't go there because I didn't want to be a service provider unit. And um, and there's a hidden assumption um, that more is better. So the people who run the health service believe that the more people you can see in a day, the better it is. And it, my belief is seeing someone in a meaningful, constructive way in the long run saves money. And I did a study with a colleague in the UK, Venetia Young, who's in Penrith, and we went through a process of implementing um, narrative medicine in her practice, in her GP practice. And in the end, she got an award from the NHS for saving them money because by spending more time and by involving the front office, the receptionists even, and the medical assistants and the nurses and everyone in the practice and the narrative process and the training and the discussions about patients, people became incredibly more efficient in the long term. And and the in the long term, the number of visits for chronic patients decreased and their cost of care went down. And everyone was happier. People were on the verge of quitting or cutting back to half time when we started this project. And by the end, they were much happier. And you can read about this project if you Google my last name, Mehl-Madrona, and Venetia Young, Young, and Permanente Journal, which is where we published it, Permanente. Um, and so I say we just have to fight back and to say no and to say I'm going to have some longer appointments with people. And in those longer appointments, I'm going to get to know them. I'm going to get their life story. I'm going to do a stress interview. I'm going to find out, what's going on with them. And in the long run, I'm going to feel more nourished, nurtured, because I'm going to have real human relationships and not I'm going to have relationships instead of transactions. You know, medicine is not like selling shoes. there's much more interpersonal relating involved. Not that selling shoes doesn't involve an interpersonal relationship, but it's a matter of degree. And that's what we have to educate our business, um, what would we say, managers, the people who are in charge of us. We have to educate them that there's more to this than checking tick boxes. That we have to you know be involved with the lives of our patients.
Mhm.
Yeah, I mean, I'm also a primary care physician. I'm a GP here in the UK, and I have 3 hours for 18 appointments, and I spend way more than 3 hours to go through the 18 appointments. At the moment, with telephone appointments, it's less of a problem, but when you have a waiting room full of people waiting to see you, then you're not really able to just take all the time that you want. And seeing patients, actually connecting with them on a human level, is what gets me through my day, not the paperwork, not all the tick boxing, not all the referrals and, reading letters and dealing with medication. So I mean, I completely agree with you there, Lewis. And when we were talking before we went live, you talked about story versus, data and algorithm. And nowadays, it seems like a lot of healthcare professionals, or because of the constraint of the system, we focus more on data, algorithm, or protocol guidelines, rather than actually seeing people as human beings and individuals. Yeah, I mean, what have you got more to say on that topic? Either of you?
I know in the mid 90s, I wrote 2 articles about the emerging field of what was then GP exercise referral schemes. So that has a strong connection to social prescribing. So the GP had the option to, rather than necessarily use a prescription, to send them somewhere else whereby they were possibly able to go on a journey that made them better without necessarily using the medicine, which was fantastic. And I think a lot of people like me were very excited that that was going to be here to stay. It did, I might add, and it is still growing. And as I'm sure some of the people out there who are listening will know, that it has made quite a major resurgence over the last 18 months in the UK. I don't know about the other parts of the world, but the thing that I commented on was that it's really impractical for the doctors themselves to get involved in that change process. Now, when I say not get involved in it, I mean they can start it off in a fantastic, terrific way by having a different mentality around how am I going to do this, so that rather than get the gentleman stood in front of me saying, why do I want to send one of my patients to a gym instructor, you're actually recognizing the value of people more like me. If I sort of move out of the way there, this is me in the middle of a Welsh forest in North Wales for a whole weekend doing a retreat, immersion in nature. So it's fantastic for me. And it's even more fantastic for the people who are there, because they can change, not like flying an aeroplane where you change from one time zone to another. They're changing the time zones within themselves. And when you slow their timing mechanism down, then a whole host of things will happen. Even to the point that quite often they're in tears in the afternoon of the first day, because they're connecting not only within themselves better, they're actually connecting to the surroundings around them, which is what slows their internal time mechanism down, if you like. So we need to find a way whereby we can get the best of you guys having some more time to be involved in the intervention, but then having appropriate places which are really geared well to allowing them to journey faster towards where it is they're trying to go with their condition or circumstance.
Exactly, Graham. I think it's about the multidisciplinary team approach that we really crave. From an A&E point of view, because patients come to us when they are really distressed initially, I think the first point is that we doctors recognize and try to learn to recognize when somebody is coming in with a chest problem. If they have come in with a chest problem, we do all of the tests. I have a story where one of our patients, 32-year-old, unfortunately came in 55 times to my A&E before I was able to see him. And on the 56th time when I saw him, I read through all of his notes, and all of the doctors, every single time, 55 times the last 3 weeks, tested him from heart problems, chest problems, anything that can kill him, but nobody actually asked how he was doing. And on the 56th time when I saw him, I actually sat down with him and I just asked, how are you? What's going on in your life? What is the story around your presentation? And it very quickly transpired that he unfortunately suffered from PTSD. And 3 weeks ago, he was forced to start a job to become he worked in a pub. So you can imagine, for somebody who was anxious about being around people, and 3 weeks ago he started working in a pub, it was quite clear the connection between his story and his presentations. But it took him 55 times to come in and to meet somebody different who is not following the guidelines but wanting to connect for this to transpire. And once we do recognize that, then we need somewhere in the system to refer these patients who are more practical and can offer them that long-term continuity of care, just like you said, Graham, and that immersion experience, because it does seem like nowadays our current system doesn't allow for that to happen. Luis, what was your experience now that you have tried to do this practice and you are and our colleagues are forced within this kind of constraint? How can we continue that care within our medical system? How could we educate our colleagues and our business-minded people to recognize this problem?
Well, I think we just have to stand our ground and tell them, no, I'm not going to see 18 people in 3 hours. That's not good medicine, and that whatever money you make up front, you're going to lose downstream, and we're just not going to do it. And in the now, I suppose lucky in the sense that I'm a faculty. I don't I'm not in a setting where anyone's asking me to see 18 patients in 3 hours. I typically I can set the length of time that I want to see someone. I can say 20 minutes, 40 minutes, or 60 minutes. And typically what I say is, give me 60, and if you can't give me 60, give me 40, and if you can't give me 40, give me 20. And mostly I end up with more than 20 because in our setting we have a tremendous number of no-shows. And we're in central Maine in the United States, and it's very rural.
Shall we carry on just for the moment?
Of course, yeah.
Yeah. I think along the same lines that Lewis is commenting here right now, if I use one example from Woodworked Wellness, the charity that I formed in 2015, I think, I had one of the people that was referred. So, we do get referrals. When he was in conversation, not on the first day, but obviously relaxed into the environment of making things, absolutely loving it. they're in a different place at that point and are more open to communicating without any pressure from anywhere. It's because they want to and they feel like they can do that they do. But I then come to realize that he's on over 1,000 tablets a month. Okay. He had complex sort of starting originally with a stroke, but then other things going on. So he had about 5 specialists. And so by this stage, he's on over 1,000 tablets a month. I simply asked him to put them all on the kitchen table, take a photograph and show your GP. And sure enough, within the space of about 3 months, all of the consultants came together and sort of recognized that, things were not quite as they should be. And to the point where now, I think he's on slightly over about 200 a month. If we looked at that as a cost saving, even in a short space of time, it just shows that, the system needs to look at itself in more detail as to which areas are they getting it right and which areas are they getting it wrong. And that was just one very simple example from the project that I'm involved with right now. Lewis, I'm sorry, but we lost you.
Yeah. Well, we're in a hotel and we arranged a late checkout, and the internet didn't know it, and so it promptly died at the appointed time, and so I had to sign back on. So anyway, I'm
Thank you for
back.
doing that.
Yeah, yeah. Um, yeah, so I was talking about, I don't know how much you heard of what I was saying, but I was talking about fighting back. And I was saying that I often get longer appointments just because I have no-shows. But you know, we've trained, we've created a clinic in which our practitioners can decide how much time they need to have with someone. That we don't have business people telling us that we can only spend 15 minutes a person. And that happened before me. I celebrate the person or people who fought that battle and won. But you can win that battle. And but I think the area that maybe is also really interesting, which you were getting at with the 55 visits, is that we have the same problem. We people um, people have chest pain, and so we give them the what amounts to the $25,000 workup, and then we say, "Oh, well, your heart's fine," and typically they look at us and say, "But I still have chest pain," you know, and we're like, "Well, we don't care. Your heart's fine. Leave, get out of here, go home." And they're like, "But nothing changed. I'm still having the same symptoms that I came here with." Right? And you probably see that too. That um, it's not patient-centered medicine that we're doing, and it's not individualized medicine. It's let's activate the algorithm medicine, and here in the United States, it's incredibly profitable because we're a profit-driven healthcare system. But I can't imagine that it's good for the NHS to to practice in this algorithm driven fashion because it just burns money. The other thing that we have is, so we have something called a code stroke. And so anyone who experiences any symptom that might, I say might, be a stroke, gets automatically a CT scan of the head, an MRI of the brain, an MRA of all the blood vessels in the brain, a carotid Doppler, carotid ultrasound, and an echocardiogram, and a speech consultation, an occupational therapy consultation, a physical therapy consultation, a neurology consultation, and gets put on aspirin, a high intensity statin, and Plavix. So that's about a $50,000 workup. So one day, I walk into the room and here's a guy in the midst of this workup, and I examine and I'm like, "Oh, you have Bell's palsy." He's like, "Really?" They told me I had a stroke, and I said, "Well, strokes don't actually behave like this. This is Bell's palsy." And I said, "If you'd come to the office instead of the emergency department, we could have avoided all this." So next time, come to the office first. Um, but my point is that because he had facial drooping, he activated the code stroke. Now, nobody bothered to see if it fit something besides a stroke, like Bell's palsy in this instance. So, I mean, and it's good for us because we made $50,000 on the deal. Um, but it's bad for society because we can't afford universal health care in this country because of the absolute insanity of how we practice. Um, but but it's getting back to treating patients instead of algorithms. One of the residents asked me this the other day. She was we had someone with severe preeclampsia who was in labor, and she was terribly frustrated because we, meaning her faculty, weren't following the algorithm. And, because the algorithm says 20 milligrams of IV labetalol if the pressure is still above 160 over 105, 20 minutes later give it 40 milligrams, and if it's still that way, 20 minutes later give 80 milligrams. And she said, and you guys aren't doing that. And I'm like, because, we don't want the pressure to go so low that we stop the blood flow to the placenta. And she said, but the algorithm says, and I'm like, but you have to treat the patient and not the algorithm. Like, it's a guideline. It's not a rule. And she's like, well, I want rules. And I'm like, well, that's not going to work. you know. So, but it's just, it's a culture change that we have to oppose because it's not healthy and it's expensive and it's not making people better.
It's
It's not
very
making them
difficult, the
well.
combination between the culture change and the litigation system that is around us. Everybody's quite scared of not following the guidelines because the high rates of suing. So where is the balance between that? It's very hard to me, but I think that's why these conversations are so important, not to forget to be human and not to forget to talk to your patients. And even if we do end up doing the test, at least to keep an open mind and to have the conversation with the patient. I think there was some statistics that those physicians who did have conversations with their patients had much lower suing rates as well.
Yes, that's a study that's been done. And in fact, there was a study that showed that if you increased the amount of time that you spent with the patient by 1 minute, it decreased the incidence of malpractice claims. It cut them in a third to one, by one third. And time matters. And
Mm.
and I think people appreciate respect. If we show them respect and we talk to them and get their opinion, and ask them, you know, what they want to do based on the risks. One of my friends in the UK did have a TIA, transient ischemic attack, and her neurologist put her on a high intensity statin, of course, and it made her muscles hurt so much that she stopped walking. And so she went back to see him and she said, it's better for me to walk and not take the statin than it is to take the statin and not walk. And so that's what I'm going to do. And so he fired her as a patient. He said, well, then I'll never see you again as a patient. And she said, fine, I'll never see you again as a doctor. But, um,
Mm.
but it was important. And because she was taking her TIA seriously, she was getting her blood pressure under control. She was walking, you know, a number of kilometers every day, increasingly so. And she was for the first time in her life really engaging in lifestyle medicine. And that's, I mean, who's to say that's less important than a statin? One of my residents figured out that um, the number needed to treat to prevent one cardiovascular event with a statin is 235. And of those 235 people, 10 of them will develop diabetes from the statin, and 4 of them will have such severe muscle problems that they'll stop moving. They'll become sedentary. And so my resident said, I guess you call them registrars where you are. My resident said, gee, no wonder all-cause mortality hasn't gone down with statins. I think I know why. And I thought, yes, I think you do know why.
That brings it back to the patient-doctor relationship, to bring that back and to empower our patients to take control of their problem and not remove that from them by taking them through multiple exams. And most of the time, we don't even explain to them why these tests are going to be done to you. But after many examinations, many technical things, we just say, well, everything is fine with you. You can go home. But they haven't even had a clue why those tests were done to them.
No, and they still have the symptoms that they came with typically. Um,
But they go home happily.
yeah, I should
Fine.
mention there's a doctor in Halifax, Nova Scotia, Canada, a psychologist who's actually being praised by the provincial health authorities for his work with people who have medically unexplained symptoms. And what they're doing in Halifax, his name is Abbas, Abass, or I think it's two B's. What they're doing in Halifax is they're getting the psychologists involved early and not after all the tests have been done and no one can find anything, but early in the game to do a life stress assessment and to start working with people to reduce their stress. And the province is finding that it's saving incredible amounts of money. So much so that they begged him to hire some more psychologists to do more of this kind of work because they're working in the emergency department. The psychologists are right there on the front line with these patients when they come in with their medically unexplained symptoms and engaging them in discussions of stress. And what he's doing, and I'm not convinced that it matters what kind of therapy you do as long as you engage the people, but what he's doing is short-term psychodynamic psychotherapy in the style of Davinlos, which is generally 12 one-hour sessions. And what he's doing, which is working, um, is to connect people with the emotions behind their symptoms. So he's finding that most of the people with medically unexplained symptoms are not able to recognize emotions when they have them, and their emotions are interpreted as physical symptoms. And if he can just reconnect them to their emotions, they'll stop going to the emergency department, which is the goal. And hopefully they'll keep working on recognizing their emotions for warning systems that tell us about how our lives are going, and give us some clues about where we may need to pay attention, to change the course of our lives.
And I know in the project in the mid-90s, directly linked to the NHS, the Canadian worksite wellness programs at that time were very advanced, and I basically suggested in the UK that we modelled the GP type exercise referral schemes. I dislike the word exercise referral because it gives suggestions of running on a treadmill or something, and I think we all know that that's not really the solution. But I think we understand the point that if a patient can attend somewhere, and the suggestion that I made was that we need to, someone like me who can sit down with them to sort of do this exploring that we're talking about right now, was anywhere between 5 and 9 in a year. And these were 1 hour sessions. Although I always gave a window on the very first session for it to potentially run to 1.5 hours. Because in that process, especially that first session, it's really about their story being able to come out. So the process that you use rather than an algorithm is one of which they're able to express their story over time. It does have a name, obviously a mnemonic, but which is LAKE, and that's lifestyle, attitude, knowledge, and external influences. And we were able to there were only 2 other schemes set up at that point in the UK, which were both a little bit North London. And what they'd done is to use leisure services in connection with the referral. And it was leisure services gym and leisure services swimming pool. And the article I wrote, it spurred me to write the article really, which was to say that in a very nice way is missing the point, because a lot of people wouldn't want to be seen dead in a swimming pool or in a gym for that matter. And the fact is that it needed to fit the story of the individual. So whatever process you develop to be able to get the best gains in the shortest possible time is to have a process that encompasses a system, and a system that works. And for me, that I touched on it with Linda a little while ago, is a thing called IQ. Now, you say to most people IQ, they think of the intelligence quota and doing a test and seeing how clever you're supposed to be. But IQ for me is really the initials of I, K, E, and W. So I is the information part of it. It's the gathering, where you as doctors would do it in your way, I would do it in my way. And there are lots of similarities in that, other than the technicalities of the kind of knowledge base that you guys have got, which is incredibly important. And the difficulty, though, is how is it delivered over a longer period of time? And I think that's where you need a system, for example, like IQ, which looks at the information gathering side of it. And from that information, you then end up with a knowledge platform. Now, that knowledge platform could be distorted and inaccurate. I could give you quotes right now from the medical world. I'll just give one very brief one, which is simply, something is rotten in the state of British medicine and has been for a long time. Now, that's Richard Smith, who was the BMJ editor for like 25 years. So when the system goes wrong, it's because this process is going wrong. So information basically gathered should lead you to having some kind of education around whatever that subject is. And we're discussing this subject right now. Now, that knowledge. So that information leads to the knowledge platform, which then leads you to give the ability to make something educational. So we can advise people, we need to go this way or that way, or we don't want to be doing that. But that process, if you don't add the final ingredient, it will just keep going around in a circle and end up in exactly the same space. GP exercise referral schemes or social prescribing, which is more termed these days, has done that. This now is certainly the 3rd major time round. And I'm hoping this time they get it right. But if you don't put the final element in, the sort of W bit on the end, which is actually wisdom. And, Lewis spoke earlier about going to an elder. And, the elders, of wherever, whether that's Aboriginal, Mayan, or wherever, because they've been around so long, that sort of wisdom element generally is born through experience. And sometimes, quite often, that's painful. So with IQ, you've got the information, you've got it leading towards the knowledge, you should then be able to educate well, but it's at the expense of wisdom. Now, in wisdom terms, we don't generally get it properly because it's either governed by ego, it's governed by politics, it's governed by maybe religion even. I'm not saying that in a bad way, I'm just saying, that sometimes that can have a pulling effect. And so it's being able to have a process that is complete so that when you go round the circle and you're back at the 12 o'clock position where you started, you're actually above, where moving towards something that is better, rather than either going around the circle and being in exactly the same place, or worse still, going round the loop and ending up worse off, which is, quite often, sadly, as you guys are touching on right now, so something has to happen there, and to
break the circle.
Yeah.
In a practical term, definitely we see it in A&E. A lot of times we just refer patients to endless specialties. Louis said we do endless examinations just for them to come back with the same problem. Doctor, my chest is still hurting. Yeah. And unfortunately, we do not address that issue at any point. And once again and again and again, we discharge the patient. But that's where the story comes in, isn't it? So to enrich that examination, that conversation with their story, so that we can actually place that symptom that they're coming in with into the whole picture, instead of just isolating it and then sending them down the guideline pathway, which is so important.
I know. In that circumstance that I've just been describing there, the initial retention figures for the two projects based just north of London, their retention figures were 9% on one of the projects and 11% in the other. At that time, Wigan was coming on board along with a place called Sefton, which is near Liverpool. And they also had a very similar kind of approach. I think we were slightly ahead of them and certainly got our results out a little bit ahead of them. And we went straight to just over 80% retention at a year. So it's about the process, and making sure that you've thought about all of the bits and pieces that are going to enable this thing to come together in the right way, so that we're forever going around the loop and moving upwards towards something that's better.
Exactly.
I noticed there was a question earlier by someone on the chat. I think it was connected more for you guys on the medical side. Have you guys seen that yet? I think he was asking about, he totally understood. I'm not sure. I think it was a he. What we're saying about this process and trying to have more time. I think the difficulty is how do we build that in? And clearly that the Wigan project, this is back in the mid-90s and towards the end of the 90s. So and more of that has happened, by the way, so it hasn't totally gone. But I think that this time round, the social prescribing and the that sort of approach, because there has been rather a lot of money put that way. It's just about whether they've thought it through, so that we don't go yet again around the loop the third time and end up back in the same place for in another 5 or 6 years or whenever, when they try and pick it back up again.
Louis, we can't hear you. You're on mute.
Sorry, I did find the question. It was from Adrian, who says that talks about aspects of practice income being linked to meeting quotas, such as blood pressure targets or providing specific services. And how would you envision tackling that part as saying no, using narrative, when it directly reduces practice income? And I actually think there's a place for a study here. And I think that getting people's life stories and getting to understand them would probably go further toward lowering their blood pressure and their hemoglobin A1C than just wagging your finger at them and telling them to go lower, to go do it.
Do something.
That, yeah. And um, I've been contemplating that study for hemoglobin A1C. So we have people who stubbornly resist any change in their hemoglobin A1C of any sort. They're not going to stop eating what they're eating because they've got a story about the kind of food that they eat. You know? And and so I have an idea for a research project of doing life story interviews and giving those to their doctor and looking at the effect of the doctor knowing the life story on the hemoglobin A1C of the patient. So if anyone wants to do it with me, we can do a multi-center trial, of lowering hemoglobin A1Cs through knowing the patient's life story.
Lewis, the thing
That sounds brilliant.
the thing I mentioned earlier about Lake, lifestyle, attitude, knowledge, and external influence, it's picture based for the individual. It's the individual's picture that gets drawn. We had to get it cleared for Wigan and Lee through the University of Manchester. And we did get it cleared. And to be honest, it is the reason why it went from 9 and 11% to in excess of 80%, just over 80% at 12 months. So yeah, I'm more than ready to take you up on that. And at some stage, I know Linda knows a little bit about Lake, but I'm quite happy for you to have a look at that, whereby we look back from where they are now when I meet them. It was the first thing that I would do with them in that 1 hour session to maybe an hour and a half tops, whereby they really feel that this is about them, and it's about them. Where am I right now? What do I really want? And that's not easy to sort of get to happen very quickly. But if the process is right again, then it does. I know Linda knows the story of one of, I worked with Manchester's gang scene for 9 years. These were proper serious youth gang members. Moss Side lost, so I mean, now's not the time for that because I think we're probably pretty short on time, are we? I don't know.
We wanted to. There's another question actually. And Adrian answered. I agree. A well-designed trial showing its benefit would be very helpful in changing the way income is generated from practices and hospital services as well. I think these kind of studies are completely overdue, and it would be amazing if this conversation would inspire us globally coming together, putting our foot down, saying no, and bringing this research to the forefront to our business-minded managers. Do we have another question here?
Yeah. The question is, given the move to virtual consulting is now likely to stay for good, do you envisage a change in how narrative medicine can work? Is part of the therapeutic process linked to face-to-face interaction? For example, Graham, with the sheds that you spoke of, do they continue to exist virtually? Can those relationships and stories naturally come about virtually as they did when held in person?
It is starting to happen that year. Most of the sheds, I mean, we're only talking about a small movement here, but it can have such a dramatic impact. The UK Men's Sheds Association have got some very interesting data from last year, about its ability to reduce loneliness and isolation. I have a Zoom meeting, or the project, when I say the project has a Zoom meeting each Wednesday at the moment. But the difficulty that we have, because most of ours are older, but not all, it's the technology side of it, and we're sort of breaking that barrier down right now. I usually do that with telephone calls with them, get them to sort of download Zoom onto the a computer, but that's quite lengthy, but it is starting to happen, and I'm sure that will just go on accelerating. One of our members who's doing that, or was doing that right now, but he's just moved south, was a 90-year-old, and he absolutely loved it. I'm not certain where the dynamics are going to go in relation to the narrative right now, but I'd really like to know. That's something over the next few months, I think, certainly 6 months, we're probably going to be able to look at in more detail. And also the fact that we've now got a major university in the UK very interested in what we're doing. In terms of this change process. So it is going to change, isn't it? I certainly on the one-to-one front, that works great. That doesn't seem to be detrimental. In my lifestyle medicine side, if I'm wearing that hat, I work extensively now with ultra late stage, primarily cancer patients who are sent home palliative care. But then we start a process then that is quite different to what they've been experiencing, and some of the results are just they blow my socks off, and that really does take some doing. Yeah.
And Louis, what is your experience going into these Zoom consultations? Is it interfering with this storytelling narrative medicine style where you are trying to connect with the patients? Do we have to sit in front of them to achieve that?
You're muted, Louis.
Not at all. I mean, I found that I'm much better able to be in contact with so many of my patients now because, they had such transportation difficulties and it's a lot of work to come into our clinic. It's a whole day affair almost. And now I can just check in with them. We can do an hour session. I can record something for them to listen to, or maybe we do a 20-minute check-in, or it's so easy now. And the other thing that's been really helpful for me with some of the people I follow is that I don't have to have office hours. I could be working in the hospital on an inpatient setting and do a quick check-in with someone for whom I'm concerned, which I could never do before because I would have had to have clinic hours. And hospital and clinic never mixed. You can't be in the hospital and be in the clinic at the same time. But now I can. I can be in the hospital and check in on someone at the same time. So I'm much encouraged by this post-COVID world of keeping track of people. And I mean, some of our, I don't know about the UK, but in the US, because we're a hospital clinic, we get a facility fee when we see people, which actually is incredibly unfair to people in private practice, because how in the world could they compete with us? Because we get an extra $176 per visit just for being a hospital. But and so we don't get that if we do it by Zoom. So some of our money people are not so fond of Zoom, but I've pointed out to them, well, you need to look at the volume that we can do by Zoom and the reduction in no-shows, and maybe you'll see that it all works out in the end when you do the math. How it looks on the surface is not necessarily how it is when you actually run the numbers. So I've been challenging them to run the numbers and see how it comes out.
Can you both tell us another inspiring story, if you don't mind, of how narrative medicine actually changed your patient's outcome? I really enjoyed the first one. If you guys don't mind, Luis, if you start with one.
Yeah, as you can see in the United States, the sun is very warm today. and it's moving around even as we um, there. That's not so bad. This sun is moving across the sky. Sure, I can tell you a story. Um, this is from when I was practicing in Tucson, Arizona, in the United States, and a young woman came to my office and said she was desperately depressed, thinking of suicide, miserably unhappy, and the more she talked, the more miserably unhappy I became. And finally, I couldn't take it anymore. So I pulled out one of my questions for those circumstances, and I said, "Seen any good movies lately?" Because I thought, well, that'll change the conversation. And in fact, it did. It dramatically changed. She just brightened up, and she said, "Yeah, Whale Rider." Now I don't know if you guys have seen that movie, but if you haven't, you should run out and get it. Well, now we don't run out and get movies, we live stream them. But so Whale Rider is a New Zealand film about a young woman who wants to learn traditional Maori cultural healing, and her grandfather won't teach her because she's a girl, and girls aren't allowed to do this, only boys. So this character whose name is Kata bribes her brother to teach her Maori stick fighting by giving him beer. So that's the that's the exchange, beer for stick fighting. And she becomes so good that she defeats all of the male students that her grandfather is teaching, which enrages him. So I won't say any more about the movie because you can watch it. And but I did say to the patient, I said, "Wow, so I don't get it. Tell me like, how do you connect with kata? Like, where's the connection? Like, what could you do to be more like her?" And she said, "It's stick fighting. I really want to learn to stick fight." She said, it looked so cool in the movie. And I said, "Well, that might be possible." So we looked for stick fighting teachers, and there weren't any Maori in Tucson, but there was a Filipino. so so I called him right there on the spot, and I said, "Hey, I've got a client here who thinks stick fighting, would really help her. Would you be willing, to add her to your classes?" And he said, "Well, how interesting. I've never taught a woman before." And I said, "Well, would you?" And he said, "Sure, why not?" He said, "This is America. We can do anything here." So I put her on the phone with him, and she found out when the classes were. And so I didn't hear from her for 2 months. And I thought, wow, I better call her. Maybe she killed herself. That wouldn't be good. And so I called her up and I said, "Hey, you didn't come back. Like, what happened?" And she said, "Oh, stick fighting happened." She said, "I'm great now. She said, "I'm, getting over my fear of men. And, because if I don't like them, I can just beat them up." And she said, "And I have more dates than I've ever had because for some reason guys want to go out with women who can beat them up." So, and she said, "And it's a whole different kettle of fish because now it's soldiers and policemen that I'm dating, you know, and not anguished existential artists." So I said, "Wow, so you've really become kata and it's cured your misery." And she said, "Yeah, I've become kata and it's cured my misery." I said, "Well, I guess you don't need me." And she said, "No, I just need stick fighting." so so that was my one session narrative cure.
Oh, this is amazing. You not only changed the story for her in the moment, but also her own story, where she has come from, where she belongs. She created a new narration for her own lifestyle.
Yes, yes.
That's incredible. And Graham, what is the one story that you would like to share with us?
I mean, obviously, like Lewis, there's so many of them, really.
Yeah.
I think the youth gang member is pretty amazing. Where are you time wise? What's
Yeah, the youth
okay
gang
for
member is a
4 or 5 minutes?
fantastic
4
story.
or 5 minutes, yeah.
Yeah.
Um, this is Manchester's youth gang scene. The first cohort group of 12 was 12 weeks long. All of the support workers didn't really see how this was going to work, were they going to try and go back into education. The idea was to try and teach them maths and English. So we basically needed to develop a process of how we do that. There is quite an important story as to how we end up on a barge 10 weeks into this 12-week program. But we'll leave that part of the story out to this bit, which all of the youth gang members, generally 14 to 17 years old, have a gang leader. They're highly respected by that group for all kinds of reasons. But most of the support workers never dreamt it would get past 1 week, let alone 2 or 3 weeks. But through having the right sort of mechanisms in place, they were still there, sort of 10 weeks in, that we decided to take them on a canal barge trip. So this was about immersion in nature again. Strangely enough, between Warrington and Chester, which is where I live now in the UK. And we got them all together on the barge. There's about 4 support workers with us, myself and my sort of support guy. And it was a fantastic day. Clear blue sky, tree lined on the right hand side of the canal. They were quite young trees, actually, fairly well spaced out. Obviously, hadn't grown much by that stage, but enough to see the sort of branches blowing across towards the canal, the wind coming from the right. The Moss Side is a notorious area, so that the black youth there were sort of just in what they know. It was it's all that they knew. So to get them to somewhere like that was a bit of an experience, we hoped, and it certainly turned out that way. Because as we're going down this with the ducks, the swans on the front, paddling around, us doing about 1 mile an hour, if that, I guess. And then the whole left side view was a panoramic view of open field, sort of grasslands apart from the motorway in the far distance. And the leader, the gang leader himself, and I might add that many of these are still in a stab vest just to go on that trip. He sat at the front of the bow with his feet hanging over the edge. And he'd been on his own for 5 or 6 minutes with no one going near him. I'd already sort of thought something isn't quite right there. I left it a few more minutes and I thought, no, something's definitely not right. So I need to sort of go down and see how he's doing. So I walked down the left side of the barge where it narrows at the front and he's there with his feet over the side. I'll call him Frank. I said, Frank, are you okay? He totally ignored me. He was just looking dead ahead at this, stunning sort of place. So I changed the words emphasis, so, it was like, Frank, seriously, are you okay? And he turned to look up at me with tears rolling down either side of his nostril, like there was no tomorrow. And his exact words were, I didn't know places like this existed. So to get that from the starting point 10 weeks earlier, where they were going to terrorize this, this thing that we'd set up as an alternative education provision, and everybody thinking that no way is that ever going to work. It simply brings me back to having the process correct in the first place, so that, the elders and the wisdom element of it all is in there, so that the process has the best possible chance. And I think, I'm I'm goosebumping now just recounting the story. That is a change. you know, that is such a colossal change. And clearly, you know, if he's still alive, you know, that would have had a profound effect on him in the long distance, because it got rid of a lot of the fog, a lot of the sort of clouds where he can't really see anything other than where he exists, to realize that another world is not that far away.
It's an incredible story as well. The power of story and the power of talking to people with all the humanity that we should have as physicians and as people can really change the outcome.
Yeah.
And as we are aware of the time, what we would love to ask from both of you, what would be the advice that you would give both to the physicians and the patients? How could we kind of demand, in a way, to change his practice? From a physician's point of view, what would be the first practical thing that you would advise Luis? And from a patient's point of view, how can they actually ask their doctors to be a bit more human with them?
I think as doctors, probably our first step is to demand more time for the more complicated people that we see, so that we can give them better care. And so I think our first step is to stand up to power and and say, you know, you're wrong. I need more time. I can't do this in the time you think I should, and because it's just not good medicine, and there are going to be mistakes. Mistakes will be made, um, and in the long run, it'll be much better to do it right the first time. And then if anyone wants to join me on my hemoglobin A1C study, you know, just send me an email and we'll coordinate it together. So, and I think for patients, um, I think it helps for patients to understand the pressures that doctors are under. You know, they think we have all this power, and we don't. Um, and maybe I mean, what I just see is they think we have power because we control the access to the opiates and the benzodiazepines. But little do they know how many regulatory agencies are watching our prescribing practices. And I think if patients are more aware of where we actually stand in terms of the power structure, maybe they could be more understanding. And in that understanding, maybe we could all share more stories with each other. And maybe patients could say, look, I got a lot of stuff going on. I need more than 20 minutes, you know, or 15 or whatever it is. Um, and maybe we can all work together to get more time.
Mm.
Yeah.
And Graham, what would be your advice in 3 points?
I think first of all, the communication network between the GPs and those providers outside of the medicine world, to be able to recognize that's already happening. It's starting to happen here in the UK, much bigger and better than it ever has before. So I'm really hopeful on that. I think organisations like ours, so, you know, the national bodies, whether that's, you know, the Welsh Men's Sheds Association, the Scottish Men's Sheds Association, UK Men's Sheds Association, and of course Ireland, well, Northern Ireland, although there are many sheds as well in Southern Ireland. You know, I know I'm mentioning the word sheds. It doesn't need to be a shed. I don't consider our project as a shed, because it's far more than that. You know, and the fact that we're able to get the people higher up in the mechanistic world of medical politics, let's say, to realize that something's going on very strange. You know, I've had several members from the mental health team, senior mental health management teams, to come down to try and understand what's going on. They totally get the fact that, you know, people going somewhere to make something, taking it home. It's all very nice. But what they really didn't get is how quick that happens and how significant it is in relation to their own health. You know, we had a guy that was, you know, a recluse, quite a young guy actually, who had gone from being a recluse in the whole house to a recluse in his bedroom. And you need to sit down for this one, for more than 10 years as a recluse in his bedroom. How does that happen? He got referred to a unit, you know, which is about, it has a name, I'm just trying to think of it at the minute. Something about being more inclusive, you know. Now he couldn't be more excluded through his own sort of story. And we changed a little bit about the approach with him, which again, you know, was him saying what his story is. And, you know, in 2.5 weeks, he came and visited the shed after being a recluse in his bedroom in excess of 10 years. So we have to get that connection going between the serious medical end of it for all the right reasons, and our kind of serious end of it, and people like me, and there are many of them in many different kinds of settings, whereby the community, it's about embedding processes that are involved in people becoming well, patients becoming well, using organizations like ours and many others in a better way.
Thank you so much. Louis just messaged. Louis, thank you so much. And thank you to both of you for coming. We are really appreciative and we learned so much from you. Louis, thank you for extending your hotel stay.
Yeah, thank you.
Thanks very much, Louis.
Yeah, bye-bye. Thank you.
Bye.
Thank you so much. Bye. Thank you so much. So we are a little bit over by half an hour. It was an amazing discussion that we just couldn't interrupt. And I'm gonna give the floor to Erica to do our breathing practice.
Okay, so Jazz is going to put the feedback form in the chat for us for those who have to go. And for those of us who wants to stay for 5 minutes for a quick breathing practice, then I'll lead you through it. So please get yourself into a comfortable position and your eyes closed or just your eye gaze down. We want to be breathing in and out through our nose and use our diaphragm to breathe and not the muscles in our shoulders, neck, and the back. So just be very mindful that your shoulders aren't moving up and down when you're breathing. And instead, you want your belly expanding like a balloon when you're breathing in and falling as you're breathing out. Today, we'll breathe in for 4 counts and hold for 4 counts, then breathe out for 4 counts and hold again for 4 counts before we breathe in again. So I'll start us off and then you can carry on at your own speed. So remember breathing in through your nose. And 1, 2, 3, 4, and hold. 1, 2, 3, 4. And breathe out. 4, 2, 1. And hold. 4, 3, 2, 1. In. 1, 2, 3, 4. Hold. 1, 2, 3, 4. And out through your nose. 4, 3, 2, 1. And hold. 4, 3, 2, 1. Breathe in through your nose. 1, 2, 3, 4. And hold. 1, 2, 3, 4. Breathe out. 4, 3, 2, 1. And hold. 4, 3, 2, 1. Just continue on your own. Remember, belly rises as we breathe in and falls as we breathe out, and shoulders shouldn't be moving up and down, breathing in and out through our nose. And as we come to a close, just notice how you're feeling now. I hope you're feeling calmer and more mindful than you did a couple of minutes ago. And I invite you to try this out when you're feeling stressed out in the week. Maybe repeat the breath cycle about 10 times, and this should take about 2.5 minutes. Now, when you're ready, slowly open your eyes. I'm seeing smiles, that's good.
Beautiful. Thank you very much. We're very grateful. And as tradition, if you feel like, please stay on for 10-15 minutes to have an informal chat. We'll start recording now. But as a little reminder, if you would like to follow up with any of our speakers, please visit us on afternoonteawithdocs.com. We have a lot of resources. Everything that we provide is completely for free, and every event is free of charge now and going forward. All we ask for is a little feedback when we do send out a feedback form, if you don't mind taking 2 minutes so that we can optimize our events for your needs. That would be greatly appreciated. Next month in January coming, gosh, the year passed so fast. We are going to cover respiratory medicine and how lifestyle medicine, nutrition, and of course narrative medicine would optimize our patients' outcomes. So we hope that you will come and join us the next few Sundays, where we will cover asthma, COPD, and other weird and wonderful respiratory diseases. So thank you very much, and we hope to see you in the next afternoon tea. Thank you, everyone.